Welcome to Studious. This lecture is your complete clinical blueprint for congestive heart failure, one of the most prevalent, most deadly, and most heavily examined conditions in all of internal medicine and cardiology. Heart failure affects over 64 million people worldwide and is the leading cause of hospitalization in adults over 65. In the United States alone, it carries a 5-year mortality rate worse than most cancers, approximately 50%. Despite these sobering statistics, heart failure is a condition where a deep understanding of pathophysiology directly translates into life-saving clinical decisions. This lecture covers the entire spectrum, from the core mechanical definition through the structural and etiological basis of failure to the hemodynamic consequences that produce the clinical signs and symptoms you will encounter at the bedside. We will then systematically walk through the diagnostic approach, echocardiography, chest X-ray, ECG, and biomarkers, followed by functional classification using the NYHA system and the complete pharmacological and device-based management protocol. Whether you are preparing for USMLE, MBBS finals, MRCP, or clinical practice, every concept in this video is exam critical and directly clinically actionable. Let us begin with the fundamental mechanical mismatch at the heart of this disease.
Heart failure is defined by a single, powerful mechanical concept: the failure of the heart to pump blood forward at a sufficient rate to meet the metabolic demands of the peripheral tissues. This is not primarily a disease of the heart in isolation. It is a disease of the mismatch between cardiac output and the body's oxygen delivery requirements. Think of it as a scale that has lost its balance. On one side sits cardiac output, the forward pump rate. On the other side sits peripheral metabolic demand, the oxygen and nutrient requirements of every organ, muscle, and tissue in the body. In health, these two forces are in perfect equilibrium. In heart failure, the cardiac output side falls, and the scale tilts irreversibly toward metabolic insufficiency. This mismatch occurs through one of two fundamental mechanisms. The first is intrinsic myocardial weakness. The heart muscle itself has lost its contractile force and cannot generate sufficient ejection pressure. The second is filling restriction. The heart's pump strength may be relatively preserved, but the volume of blood it receives during diastole is so reduced by structural constraints that the stroke volume is critically inadequate. Every clinical feature, every investigation finding, and every therapeutic target in heart failure traces directly back to one or both of these mechanisms. Mastering this concept is the master key to the entire subject.
Heart failure exists in two structurally distinct forms, and distinguishing between them is fundamental to both diagnosis and treatment selection. Systolic failure, also called heart failure with reduced ejection fraction, or HFrEF, is the forward failure phenotype. In this form, the heart muscle becomes dilated, thin-walled, and globally weak. The left ventricle cannot generate sufficient contractile force during systole to eject an adequate stroke volume. Blood pools within the dilated chamber, and systolic volume rises, and forward cardiac output falls. Think of a balloon that has been overstretched. It has lost its recoil. Echocardiographically, this presents as a large, poorly contracting ventricle with a reduced ejection fraction below 55%. Diastolic failure, heart failure with preserved ejection fraction, or HFpEF, is the filling failure phenotype. Here, the myocardium becomes hypertrophied and abnormally stiff. The wall thickens, reducing the chamber lumen size. During diastole, the rigid ventricle cannot relax and fill normally. The compliance is lost. The contractile mechanism itself may be intact, but because filling is severely restricted, the stroke volume delivered per beat is critically low. Ejection fraction is normal or even supernormal, yet the patient remains in heart failure because the absolute volume ejected is insufficient. HFpEF now accounts for more than 50% of all heart failure cases globally, making it the dominant phenotype in clinical practice.
Understanding what drives the heart towards systolic or diastolic failure requires a systematic etiological framework. The causes of systolic, forward failure cluster around three pathological mechanisms. The first is dead tissue from ischemia or infarction. When myocardial cells die following a heart attack, they are replaced by non-contractile fibrous scar. The remaining viable muscle must compensate, but as infarct burden accumulates over time, global contractile failure develops. Coronary artery disease and myocardial infarction are the single leading cause of heart failure worldwide. The second is leaky valves, specifically regurgitant valve disease. In mitral or aortic regurgitation, a significant fraction of the stroke volume is ejected backward through the incompetent valve rather than forward into the aorta, creating chronic volume overload that progressively dilates and weakens the ventricle. The third is floppy muscle, dilated cardiomyopathy induced by cardiotoxic drugs, including chemotherapy agents like doxorubicin, alcohol-induced cardiomyopathy, chronic uncontrolled hypertension, and viral myocarditis. The causes of diastolic, filling failure, are equally important. Hypertrophic cardiomyopathy involves pathological myocardial hypertrophy that reduces chamber compliance. Constrictive pericarditis involves a thickened, calcified pericardium that physically encases the heart, preventing diastolic expansion. And restrictive cardiomyopathy, caused by infiltrative diseases such as amyloidosis, sarcoidosis, or hemochromatosis, deposits abnormal substances within the myocardium, preventing normal relaxation.
Echocardiography is the gold standard investigation in heart failure, and its central diagnostic value lies in its ability to measure the ejection fraction, distinguish systolic from diastolic failure, identify regional wall motion abnormalities indicative of prior ischemia, and detect valvular pathology. The ejection fraction is the percentage of the end diastolic volume that is ejected with each heartbeat. Normal ejection fraction is 55% or above. This 55% threshold is the pivotal diagnostic split in heart failure classification. When the ejection fraction falls below 55%, the diagnosis is systolic heart failure, also called HFrEF, meaning the ventricle has lost its pumping capability. Blood accumulates within the chamber, forward output is reduced, and the patient's symptoms are driven by both poor perfusion and backward congestion. When the ejection fraction is normal, above 55%, and heart failure symptoms are still present, the diagnosis is diastolic heart failure, HFpEF. Here, pumping capability is mechanically intact, but the small, stiff, hypertrophied chamber accepts too little volume during diastole. The ejection fraction can be deceptively normal or even elevated, masking the critically low absolute stroke volume. Beyond ejection fraction, echocardiography identifies regional wall motion abnormalities, pointing to prior myocardial infarction, the presence of valvular regurgitation or stenosis driving volume or pressure overload, and pericardial effusion or thickening in constrictive disease. No single investigation provides more diagnostic information in heart failure than a well-performed transthoracic echocardiogram.
Heart failure can be elegantly understood using the metaphor of a directional traffic jam in a closed circulatory loop. The cardiovascular system forms a continuous circuit. The right heart pumps deoxygenated blood through the pulmonary circulation to the lungs, which returns oxygenated blood to the left heart, which pumps it through the systemic circulation to peripheral organs and tissues. When any chamber in this circuit fails to pump forward effectively, the blood that cannot move forward has nowhere to go but backward, backing up into the anatomical structures that feed that chamber. This is called retrograde congestion, and it is the mechanism behind virtually every clinical sign and symptom of heart failure. Left-sided failure produces retrograde backup into the pulmonary circulation. The lungs fill with fluid, producing pulmonary edema, crackles, and respiratory distress. The pulmonary capillary wedge pressure rises, transudation occurs across the alveolar capillary membrane, and gas exchange is impaired. Right-sided failure produces retrograde backup into the systemic venous circulation. The superior and inferior vena cava, the hepatic veins, the portal system, and the peripheral venous networks all become congested. This manifests as jugular venous distension, hepatomegaly, ascites, and peripheral edema. Clinically crucial, in most patients, long-standing left heart failure eventually causes pulmonary hypertension, which overloads the right ventricle and produces secondary right heart failure, creating the combined congestive picture from which the term congestive heart failure derives its name.
Right-sided heart failure presents predominantly with objective, examiner-detectable clinical signs rather than subjective patient symptoms, a distinction that is frequently tested in examinations and critical to bedside recognition. When the right ventricle fails to pump blood forward into the pulmonary artery, blood backs up into the systemic venous circulation, causing venous hypertension throughout the entire body. The clinical signs follow the anatomy of venous drainage. In the head and neck, elevated central venous pressure is reflected directly in the external and internal jugular veins, producing jugular venous distension, or JVD. This is one of the most specific signs of right heart failure and elevated right atrial pressure. In the hepatic circulation, venous engorgement of the hepatic veins produces congestive hepatomegaly. The liver becomes enlarged, tender, and pulsatile in tricuspid regurgitation. Concomitant splenomegaly develops as the portal system backs up. In the gastrointestinal tract, congestion of the mesenteric veins produces intestinal edema, leading to anorexia, nausea, vomiting, and indigestion, symptoms frequently misattributed to primary gastrointestinal disease. Ascites develops from hepatic congestion and elevated portal pressure combined with hypoalbuminemia in chronic failure. In the extremities, elevated venous hydrostatic pressure forces fluid from capillaries into the interstitium, producing bilateral, dependent pitting pedal edema, classically worse at the end of the day after prolonged standing and improved after overnight recumbency.
Left-sided heart failure presents through two simultaneous and equally important pathophysiological consequences: backward pulmonary congestion and forward low cardiac output. Both must be recognized and addressed clinically. The pulmonary congestion syndrome results from retrograde backup of blood into the pulmonary vasculature. As pulmonary capillary wedge pressure exceeds approximately 18 millimeters of mercury, fluid transudates across the alveolo-capillary membrane into the alveolar air spaces. On auscultation, this produces fine bibasal crackles, the hallmark of pulmonary edema, along with wheeze, cough, and frothy blood-tinged sputum in severe cases. Tachypnea develops as a compensatory respiratory response. The positional dyspnea syndromes are particularly diagnostically important. Orthopnea is dyspnea that worsens in the supine position and is relieved by sitting upright. When the patient lies flat, venous return from the lower extremities increases, augmenting preload and worsening pulmonary congestion. Paroxysmal nocturnal dyspnea, PND, is the dramatic syndrome of waking from sleep gasping and breathless, typically 2 to 3 hours after lying down, relieved by standing at an open window. It represents the delayed redistribution of interstitial fluid back into the intravascular compartment during recumbency. The low output syndrome, the forward failure component, produces cold, mottled extremities, weak peripheral pulses, fatigue, exercise intolerance, and in severe cases, cardiogenic shock with confusion and oliguria.
The clinical distinction between left-sided and right-sided heart failure is a cornerstone of bedside diagnosis, and the conceptual framework for remembering it is built around two contrasting principles. Left-sided failure is dominated by symptoms, the subjective experiences that the patient reports, driven by pulmonary congestion and impaired systemic perfusion. The patient complains of breathlessness, orthopnea, paroxysmal nocturnal dyspnea, fatigue, and exercise intolerance. The backup location is the lungs, and the key clinical indicators are bibasal crackles on auscultation, orthopnea, PND, and weak peripheral pulses from low output. Right-sided failure is dominated by signs, the objective findings that the physician detects on examination, driven by systemic venous congestion. The patient may not volunteer specific complaints, but examination reveals jugular venous distension from elevated central venous pressure, hepatosplenomegaly from hepatic venous engorgement, ascites from portal hypertension, and bilateral pitting peripheral edema from elevated capillary hydrostatic pressure. The backup location is the systemic venous compartment. This left equals lungs and symptoms versus right equals systemic and signs framework is the clinical shorthand that drives rapid bedside diagnosis. In clinical reality, most patients present with biventricular failure, the combined picture of both pulmonary and systemic congestion, because chronic left heart failure eventually overloads the pulmonary vasculature, elevating right ventricular afterload and producing secondary right ventricular dysfunction.
Alongside echocardiography, 3 adjunct investigations form an essential diagnostic triad in the workup of heart failure: the chest X-ray, the ECG, and the serum BNP level. Each provides distinct and complementary information. The chest X-ray is the first-line imaging modality for assessing the degree of pulmonary congestion. Key findings in heart failure include cardiomegaly, a cardiothoracic ratio exceeding 50%, upper-low blood diversion reflecting pulmonary venous hypertension, and curly B lines, short horizontal lines at the lung bases representing thickened interlobular septa filled with edema fluid. Bilateral perihilar haziness in a batwing pattern indicates frank pulmonary edema. Pleural effusions, typically bilateral, develop from elevated pulmonary capillary pressure, causing fluid transudation into the pleural space. The ECG is almost always abnormal in heart failure, though no single pattern is diagnostic. It identifies the underlying etiology: Q waves from prior myocardial infarction, left ventricular hypertrophy in hypertensive or hypertrophic cardiomyopathy, left bundle branch block indicating dysynchrony, or atrial fibrillation, both a cause and a consequence of heart failure. The BNP, brain natriuretic peptide, is secreted by ventricular myocytes in response to wall stress from volume overload. An elevated BNP above 100 picograms per milliliter confirms decompensation. Critically, a normal BNP in a dyspneic patient effectively rules out heart failure as the cause, making it an invaluable rule-out biomarker in the emergency setting.
The New York Heart Association Functional Classification System, the NYHA classification, is the universally adopted framework for quantifying the functional severity of heart failure based on the relationship between physical activity and symptom onset. It has 4 classes that map clinical disability onto a spectrum, from full function to complete incapacitation, and it directly determines the intensity of pharmacological management. NYHA Class 1 represents no functional limitation. The patient can perform ordinary physical activity, climbing stairs, brisk walking, carrying groceries, without any symptoms. Heart failure may be present structurally or biochemically, but the patient remains asymptomatic during normal activities. NYHA Class 2 represents mild functional limitation. Ordinary physical activity produces symptoms. The patient becomes breathless or fatigued walking through a park or climbing one flight of stairs, but they are comfortable at complete rest. NYHA Class 3 represents marked functional limitation. Less than ordinary activity provokes symptoms. Simple activities of daily living, dressing, washing, walking from room to room, cause distress. The patient is only comfortable at rest. Class 3 is a critical threshold in pharmacological management, triggering the addition of loop diuretics and aldosterone antagonists. NYHA Class 4 represents complete inability to perform any physical activity without symptoms. The patient is confined to a bed or chair and experiences symptoms of heart failure even at rest. This class carries a 1-year mortality rate exceeding 50% without advanced intervention, such as cardiac transplantation or mechanical circulatory support.
The pharmacological management of heart failure follows a systematic escalation protocol tied directly to NYHA functional class, adding therapeutic layers as disease severity progresses, with each layer targeting a specific pathophysiological mechanism. The foundation layer, applied from Class 1 onwards, consists of 2 disease-modifying agents that prevent adverse cardiac remodeling. ACE inhibitors, such as enalapril, lisinopril, or ramipril, block the renin-angiotensin-aldosterone system, reducing neurohormonal activation, lowering afterload, and critically preventing the progressive ventricular dilation and hypertrophy that accelerates disease progression. Beta blockers, specifically carvedilol, bisoprolol, and metoprolol succinate, counter the harmful effects of chronic sympathetic nervous system activation, reducing heart rate, myocardial oxygen consumption, and the risk of fatal arrhythmias. Both drug classes have level A evidence for mortality reduction in HFrEF. At class 3, a loop diuretic, most commonly furosemide, is added to manage symptomatic volume overload and pulmonary edema. Furosemide blocks sodium, potassium, and chloride reabsorption in the thick ascending loop of Henle, producing rapid natriuresis and diuresis. Significant hypokalemia is a critical monitoring concern. Also at class 3, spironolactone or isosorbide dinitrate hydralazine provides additional mortality benefit. At class 4, positive inotropes, digoxin and dobutamine, are added to force contractility in cardiogenic shock, though with the important caveat that will be discussed in the next segment.
The pharmacological management of heart failure contains one of the most conceptually challenging and clinically dangerous paradoxes in all of cardiology, the inotrope paradox. Understanding it is essential because misapplying inotropic therapy can convert a chronic disease into a rapidly fatal one. The failing heart can be vividly imagined as an exhausted old horse pulling an enormously heavy cart of blood. Every beat, every contraction requires greater effort with less reserve. Inotrope drugs, most classically digoxin and in the acute setting dobutamine, act as a whip applied to this horse. In the short term, the whip works. The horse runs faster, pumps harder, cardiac output increases, pulmonary congestion is relieved, symptoms improve dramatically. The patient feels better. This is the clinical seduction of inotropes. But here is the paradox. The excessive mechanical workload imposed on an already failing myocardium dramatically accelerates myocardial cell death and arrhythmogenesis. The clinical consequence is stark. A heart that might have functioned for another 2 years under conservative management will, after chronic inotrope therapy, succumb in as little as 2 months. Multiple landmark trials, including the PROMISE trial with milrinone and the OPTIMIZE CHF trial with dobutamine, have confirmed that chronic oral inotrope therapy significantly increases mortality in heart failure. Inotropes are therefore reserved exclusively for acute decompensated heart failure in the intensive care setting, as a bridge to transplantation or mechanical support, never as routine chronic outpatient therapy.
One of the leading causes of death in heart failure patients is not progressive pump failure. It is sudden cardiac death from fatal ventricular arrhythmias. In a severely dilated and dysfunctional ventricle, heterogeneous conduction across zones of fibrosis and viable myocardium creates the substrate for ventricular tachycardia and ventricular fibrillation. These arrhythmias can occur without warning and produce cardiac arrest within seconds. The threshold for this catastrophic arrhythmic risk is an ejection fraction below 35%. Patients with EF below 35%, regardless of whether they are NYHA class 1, 2, or 3, carry a constant high-level risk of sudden fatal arrhythmia and require primary prevention. The therapeutic solution is the automated implantable cardioverter defibrillator, the AICD. This device is surgically implanted, with sensing leads threaded transvenously into the right ventricular apex. The AICD continuously monitors the cardiac rhythm in real time, 24 hours a day, 7 days a week. If it detects a malignant arrhythmia waveform, ventricular tachycardia, or fibrillation, it delivers a high-energy shock directly to the myocardium within seconds, terminating the arrhythmia and restoring sinus rhythm before the patient loses consciousness. In the landmark MADIT-2 trial, AICD implantation reduced mortality by 31% in patients with prior MI and EF below 30%. Current guidelines mandate AICD implantation in all symptomatic heart failure patients with EF below 35% despite optimal medical therapy.
Successful long-term heart failure management rests on 3 simultaneous pillars: halting adverse cardiac remodeling through neurohormonal blockade, managing chronic volume overload through strict fluid and sodium restriction, and reducing arrhythmic mortality through device therapy. The strict fluid and metabolic limits are non-negotiable and must be communicated to every patient. Salt intake must be restricted to less than 2 grams per day, equivalent to approximately 1 teaspoon. This directly reduces fluid retention by limiting the osmotic drive for sodium and water reabsorption. Fluid intake must be restricted to less than 2 liters per day to prevent volume overload. Strict control of underlying hypertension the most powerful modifiable driver of diastolic failure and progressive LV remodeling, and blood glucose control in diabetic patients are essential, as both diabetes and hypertension are independent accelerators of cardiac dysfunction. The three mortality-reducing medications in systolic heart failure are ACE inhibitors, beta blockers, and spironolactone, each proven in large randomized controlled trials to independently and additively reduce all-cause mortality in HFrEF. The Consensus trial established ACE inhibitors. The CIBES-2, MERIT-HF, and Copernicus trials established beta blockers. The RAILS trial established spironolactone. Together, these three agents form the cornerstone of evidence-based heart failure pharmacotherapy. As we close, remember, heart failure is managed through the integration of pathophysiology, pharmacology, and patient education. Please like, comment, share, and subscribe to Studious for more high-yield content like this.